I guess Dr. Freeze says we've got a quorum, so thanks everybody for your persistence. I'm Steve Tower, graduate of this program in these fine graduating classes shoes 30 years ago. And it's really kind of, Rod Beals, every once in a while, Rod was a guy of very few words. And every once in a while he'd say, you'd go into this long story about something and he'd sit there and listen to you patiently. He says, yeah, that's kind of cute. So I think what Rod would say about this timing of this is kind of cute that I would be giving this presentation here 30 years after graduating from the program. But Rod was just an amazing chief. And a lot of this talk, I would not be in this position without Rod. I don't think I would have ever figured out this particular issue or had the means or the skills in order to figure it out had it not been coming through this program and having this Rod Beals experience. You know, Zersky, some of the other guys here, all experienced this. Rod would come up to you after he got to know you after a year or so, usually first year of training. And when I went through all this, they gave you a couple of months off, was it, Zersky? 3 months, yeah, to do a research project. And I visited every orthopedics office in the state to assemble 100 different interventions for periprosthetic fractures of the femur. Until quite recently, it was the largest series of that type in the literature, widely quoted, and we learned a lot. A lot of these things were being treated conservatively, and conservative treatment sucked for that particular injury. And that was the Rod style. It wasn't flash. You weren't using supercomputers. These weren't double-blind controlled randomized trials. But he gave you, and Rod, it was, if I remember correctly, it was 3x5 cards or 4x6 cards, and he put each case on that. But it was this patient means of assembling a series of cases and trying to make some sense out of it. So what makes this particularly interesting is the multiple aspects of this particular story, which actually starts with me being a patient, and it's also kind of, Rod would say, cute, that I got my ASR hip 12 years ago when I came back to OHSU for what I call a 2-for-1 trip. I had bilateral arthritic hips. I had a chondroosteoplasty on one side. A week later, Tom Ellis put my ill-starred DePuy ASR hip in my other side. I wasn't in the hospital but overnight both times, much against Tom Ellis's concern and recommendation. I remember after both operations, I got up and they hadn't opened that wonderful overpass to the VA. And I went out as my initial maiden postoperative voyages and did that hike on sticks. And then got discharged the next morning. But that's how this story started. I am actually the index case of Arthro-Prosthetic-Cobaltism from a contemporary metal-on-metal Chrome-Cobalt implant. And I also wrote my own case report, which was of 2 patients. The only patient I put an ASR in had my same issue, and he was in the case report that did finally manage to get published to Journal Bone and Joint, but only after I had to sabotage the usual method of peer review, because it got stacked up beside the section editor for hip and joint reconstruction, who was a DePuy consultant. And I had the very interesting experience of when this was published in Journal of Bone and Joint, to actually have a commission commentary by the American Presidential Line of the American Academy of Orthopedic Surgeons, basically saying, we don't believe this exists. And 3 out of 4 members of the presidential line of the orthopedic of the academy at that time had significant conflicts of interest with industry. And it was a matter of 5 years after that, and I think up until the most recent academy, I've had 12 submissions to academy, 10 declined. I finally succeeded in getting 2 posters accepted. But it's been a very interesting story because it's a personal experience. The science is very interesting as to the whole history of cobalt toxicity and how it was recognized when it was used as a hematemic in medicine in industrial exposure cases. And actually, although I was the first case reported related to contemporary metal-on-metal hips, when I did my case report, I did find, I think at that time, 3 other case reports of severe cobalt poisoning from arthroprosthetics, but they were all in the setting of wear of a Chrome-Cobalt head by ceramic. And these were patients that generally, with the exception of 1, had had a ceramic on plastic total joint, went on to have a ceramic head fracture, and then were revised to a Chrome-Cobalt on plastic articulation. And the ceramic debris remains behind, becomes embedded in the polyethylene, and it will wear the Chrome-Cobalt head to a nubbin. And these remain the most severe cases of cobalt poisoning by any mechanism in the literature, be it industrial exposure or otherwise. And these patients uniformly were deaf, blind, many were in heart failure, and a fair number were wheelchair bound due to severe peripheral neuropathy. The industrial exposures were similar in terms of cranial and peripheral neuropathies, but also a fair number of reports of severe cardiomyopathy. So I'm going to focus this a little bit on what we've learned over the past 3 years since I've been in solo practice. I became very passionate. You can imagine when you get bitten by this snake, you might really want to understand it. And fortunately, in my case, my own illness was readily reversible once my hip was revised 42 months after my primary operation. And I got most all of my marbles back. Some people would contend that I'm still a French fry short of a Happy Meal. But I mean, all of a sudden I realized, whoa, this is an incredible opportunity to learn something. And my group practice did not share my enthusiasm for studying this practice. So 3 years ago, I wound up in solo practice, which turned out, a lot of these things turned out to be serendipitous. I wound up in a building with an imaging center downstairs with a double-boarded nuclear medicine physician radiologist. And this is not following the slides terribly well, but to make a long story short, I was reviewing a metal suppression MRI of a hip in a metal-on-metal patient, telling him my tale of woe of being involved in describing the systemic cobalt toxicity related to hip implants. He just lit up and said, "Steve, send me one of those, we'll get an FTG PET brain scan." And until that time, since my own experience, that of one of my patients, and then tracking down the 6 metal-on-metal patients I did, and then seeing the other metal-on-metal patients in the community, I'd accumulated probably about 30 cases of patients that were all complaining of the same thing. But these are all on the soft end of the neurologic scale. These people were complaining of primarily fatigue, new sleep disorders, irritability, moodiness, very much on the soft end. And people say, gee, Tower, these people are getting older, what do you expect? People do lose energy, they get forgetful, how? And I said, well, this is beyond that. They're developing this within years of getting one of these metal-on-metal hips, or as the story goes, unfortunately, this problem is expanding to metal on plastic hips where there's a potential for trunnion corrosion. And I talked to many of these patients, and again, I'm apologetically passionate about the topic, having experienced it myself, and heard the same story again and again, but then also hearing when these patients, and most of these patients have problems at their arthroplasty, they have an adverse reaction to metal debris. And the other observation is, you revise these people, these symptoms go away. And that was my experience. But suddenly, the ability to actually image it has been the huge breakthrough in my understanding of this in the past 3 years, which correlated with my going into private practice and meeting Dr. Bob Bridges, and he was the one who introduced me into the FDG PET brain scan. FDG PET, as most of you are familiar with in the room, is widely used imaging modality that's commonly available in almost any community. But this is a limited study of the brain. So here's I won't go into the spittoon joke, but this whole cobalt experience, first I experienced it with the ASR, and I said, well, hopefully, this will only be a problem with the worst of the metal on metals. And the ASR was the worst of the metal on metals. And then a year went by, and we'll show you some of these other cases, and said, oh no, we're seeing it pretty much in all the metal on metals, including the hip resurfacing patients. Well, thank God, we're giving those up, and there were only about 1 million put in. But then the next thing that happened was we started to see the Stryker rejuvenates, which were the canary in the mine for taper corrosion, because they had the ability to corrode at either end of a modular Chrome-Cobalt neck. And you could get a patient that was cobalt toxic and had a reverse reaction to metal debris, even if they had a ceramic head, because of the potential for corrosion at the base of the Chrome-Cobalt neck. And you say, oh shit, we're seeing this problem now in non-metal on metal patients. And at this point, I'm feeling pretty superior in my judgment as what to use in my patients, because I never did the rejuvenants. I only did 6 metal on metals. I said, gee, Tyler, you're a pretty smart guy not to get suckered down that road. Well, all of a sudden, I started seeing it like crazy in my patients with Zimmer 1214 tapers that I'd use 32 millimeter heads on. I never went to really big heads, and even more frequently in a smaller number of patients that I use Stryker accolades with V40 tapers, which is a really underpowered taper in my opinion. So I said, well, this is really looking grim. At least in my practice, the at-risk population is basically expanded to most patients. 1,000 or so hips I've done in my career are at risk. There's differences as far as how long it takes the patients to develop the cobaltemia, how long it takes for them to develop symptoms at the hip, if they develop symptoms at the hip. And then over the past year, I'm sorry guys, I'm seeing it in shoulders too. So the whole concept of an at-risk arthroplasty is now extended to anybody with a hip or shoulder arthroplasty that has a modular Chrome-Cobalt part. So I think if you look at the United States population, probably our at-risk population for this problem is between 5 and 10 million patients. And then you can multiply that by 3 to get a world number. So this is a focused review of my last 3 years of experience since I realized that patients were at risk even with a metal on plastic hip or shoulder arthroplasty. I have screened 154 patients that have walked through my new solo practice door. Sole criteria for screening is they have a joint at risk, shoulder or a hip with a modular Chrome-Cobalt part. More than half of those patients, the second number, is the 39 patients during the same period of time where I think I've reasonably confirmed the diagnosis of arthroplastic cobalt encephalopathy, or ACE, either by brain imaging in 37 patients. 2 patients we did not have brain imaging, but they had reversal of hard neurologic findings and the soft neurologic findings within a year post-revision surgery and return to cobalt negative status. The second number, 45, those are patients that are peeing cobalt, many of whom have 2 or more symptoms consistent with cobaltism. So those patients, I don't know whether or not they have cobalt encephalopathy. I don't have imaging on them. I haven't revised them to test them for reversibility. There's 70 patients in the series that I don't believe have cobalt encephalopathy because they are my cobalt negative patients. So their blood cobalt level is 0.4 parts per billion or less, or their urine cobalt level is 1 part per billion or less. I developed something primarily based on a couple things. One was a review paper that Eric Wobler wrote with me of the literature, and frankly, a lot of it based on my own personal experience of the symptoms of cobalt encephalopathy. I experienced 10 of the 12. And the most common ones are tremor, forgetfulness, and fatigue. A lot of the older patients start having falls, disordered mood, disordered sleep in about a third of the patients, in addition to kind of chronic pain or generalized pain type syndrome. And it's only about 1/3 of the patients that have hard neurologic findings in far as either peripheral or cranial neuropathies. If you take a look at the 132 of these patients did not have metal-on-metal hips. They had modular Chrome-Cobalt components. This is a larger subset of patients, and if you try to make correlations between their level of urine and blood cobalt elevations and how sick the individuals are, I've learned it's good to separate the metal-on-metals from the non-metal-on-metals. The metal-on-metals can generate particulate debris. Frequently, the patients can have very high levels. And I've seen some patients with metal-on-metals have very high levels and no apparent symptomatology. And there's a literature that's evolving relating to the pathomechanics of cobalt toxicity, which explain that the particulates are less likely to be toxic than the cobalt that's produced by a corrosive mechanism, because you're dealing with primary chemical compounds that can get in across cell membranes. What we've also learned about the pathophysiology is there's probably pretty significant individual variability as to the susceptibility to the cobalt toxicity. Relates probably primarily, according to a group of Italian researchers, relates to affinity for albumin binding of cobalt, which is individually variable. But if you take a look at my patients, and when I do this cobalt symptom inventory, and again, I get this criticism all the time, these patients are getting older. Jesus, my patients all have at least 4 of these. When I give this inventory to patients, I pose the questions to them as, are you more forgetful than you would expect for your age or your peer group? Is this a new symptom since your hip was placed? And presently, in more than half of the patients, I did not know their cobalt level at the time I did the inventory. Early on, as this was developing, a lot of the patients I did know their cobalt status. But over the past year and a half or so, we're doing this routinely as the patient walks in for their first encounter. So I'm reasonably confident that I've been administering this inventory in a relatively neutral fashion. But if you just take a look at two variables and you make them dichotomous groups, cobalt positive is defined as urine cobalt greater or equal to 1, blood cobalt greater than or equal to 0.4, and whether or not they have 2 or more of the cobalt symptoms on the symptom inventory. And you just do a simple contingency table and Fisher's exact, you get 0.0001. If you try to treat the cobalt as a continuous variable and you do a test of means with a student's two-tailed t-test, you're getting to approach significance with the blood level, but again, you're getting that 0.0001 if you look at urine as a absolute. Pretty much all the patients, with few exceptions, are in trouble in the metal on metal category. When I put this paper into New England Journal of Medicine 4 months ago and had it rejected, one of the criticisms was that, I lost my thread. That must be cobalt coming back. Oh, yeah, that was right. One of the criticisms is, well, this isn't pertinent. No one cares about this anymore because we've given up on metals. Metal on metals are passé. Why are you worried about this tower? Well, I'm worried about it because about 1 million were put in. Probably only about 200,000 have been revised, and nobody's monitoring the patients who have them. And nobody in orthopedics wants to. I can tell you that. Now you extrapolate, and one of the same guys who made that criticism, the metal says, oh, don't worry about the modular Chrome-Cobalt heads anyway, because surgeons are steering away from those. Well, according to the American Joint Registry, 60% of our primary arthroplasties are still using modular Chrome-Cobalt heads. So it's a huge problem for metal on metals. It's a much bigger problem now that we're dealing with metal on plastics. So if we take a look at my purest population, which are the 39 patients that I believe beyond a reasonable doubt I've confirmed the diagnosis, either by brain imaging or by reversal of pathology after revision, mean blood cobalt to 3.5. Now, in the early stuff with metal on metals, 10 years ago when I published my first report, people weren't getting excited about the metal on metal patients unless they had a blood cobalt greater than 7. And this has been and then as you follow the literature, people start realizing there's this individual variability even with the adverse reactions to metal debris. And I think those of us who do arthroplasty have seen patients with adverse reaction to metal debris at the hip with big pseudotumors who have very minor elevations in blood cobalt. So clearly there's this whole issue of patient susceptibility. And in my experience, the susceptibility applies both to problems at the hip and the systemic issues. Urine cobalt is generally on average 3 to 4 times blood cobalt. So you have a mean urine cobalt blood cobalt ratio of 4. Age is screening when the patients walked into my office, mean age is 67. Another reason a lot of orthopedic surgeons don't want to deal with this issue, by the time the problem walks into your door, you're generally dealing with a payer disadvantaged population, at least in Alaska. And some people say, hey, they're old people, leave them alone. So what if they need to go into a nursing home a couple years before their time? Pretty much equal ratios in gender. Mean implantation of the joint at risk at the time of screening was close to 10 years. Mean latency to systemic symptoms was 6 years. And the majority had symptoms at the joint at risk. but it wasn't a big majority. So I'm seeing a lot of patients with systemic symptoms and confirmed brain scan abnormalities that do not have symptoms at the joint at risk. When I was at Academy in New Orleans, and I went to the Hip Society meeting that was on metallosis and corrosion, they had the panel, and the panel leader of all people was Dr. Thomas Schmalzried, the design surgeon of the ASR. And of course, these guys are saying, hey, this is not a big problem, and you don't need to go looking for the systemic issues unless a patient has a problem at the hip. Not true in my experience. So the bottom line is most of these patients that are presenting to my practice have systemic symptoms before they develop symptoms at the joint at risk. Revision, these people tend to get better if you get rid of the cobalt. They tend to get better at the joint if they have an adverse reaction to metal debris. Their systemic symptoms also tend to resolve. So the real breakthrough in my mind, in my practice, has been the ability to image it. And this is what this is the more visual of the two programs, which is called Neurostat. This is Dr. Mirishima's. He was in Seattle, he's now in Salt Lake. His group is presently reviewing our 37 FDG PET brain scans. We also used a more analytic program, which is Dr. Silverman's program, I think out of UCLA at Los Angeles area, I believe, which gives you, it's much more granular. It kind of actually analyzes 240 different regions of the brain. But regardless of which program is used, we see the same pattern. The pattern is generalized brain hypometabolism. These are compared to age and gender matched norms in the libraries that are associated with the program. And not only are the brains hypometabolic, they are severely hypometabolic in a focal fashion in a pattern that is distinctly different from the described dementias, Alzheimer's, frontotemporal, and Lewy body. And the pattern of hypometabolism fits into this category called chronic toxic encephalopathy, which has been described in other heavy metals, solvent exposure, carbon monoxide exposure, and chemobrain. Again, out of the 37 patients that we've scanned, we've repeated the brain scans in 10 patients 6 to 12 months after revision surgery, and in general, the scans get better if the patients get better. We've got one patient that may have some confounding neuropathology. This is a case report that Eric wrote up. This is not in the series. This predated the brain scanning, although we did get a follow-up FDG PET on this man. So he's a pilot, commercial pilot with his own air service in Fairbanks. He gets bilateral metal-on-metal Biomet Magnum hips done at a relatively early age. Within 3 years of his arthroplasty, develops disabling Parkinson's disease as confirmed by DAT scan, which is supposed to be very specific for Parkinson's disease. He requires a deep brain stimulator, full medication regimen before it's realized that his cobalt levels are elevated. Cobalt levels are only measured once he develops symptoms at one of his hips. Cobalt levels 116. We revise sequentially both hips. Eric makes sure Dartmouth Biomedical got his retrievals. They did a nice retrieval analysis, which really glossed up the case report, which was in JBJS Case Connector. But the bottom line was within 2 years of revision surgery, this guy's Parkinson's all but went away. He's been able to turn off his deep brain stimulator, he's off drugs, and out of all the patients we have scanned to date, 5 years after his revision surgery, he has the most normal FDG PET brain scan of any of ours. He's only got one hypometabolic region or cluster in his study. This hits home. This is, again, this lady is not in the series. This is my early experience. This lady's a perioperative nurse. One of my former partners did this BHR, bailout total hip, which was supposed to only be available if you got into a resurfacing situation and decided it wasn't an ideal candidate for resurfacing. She's a relatively young woman. She had hip dysplasia. So as far as her hip was concerned, she thought she was doing great. But 3 years or so after her procedure, she develops a tremor, makes it hard for her to start IVs, and her memory is getting very poor, plus she's getting quite irritable to the point where she's concerned about the quality of her work as a nurse. Yet she's seeing my partner in the perioperative area on almost a weekly basis, and how's the hip? Oh, the hip's great. And so it's only 3 or 4 years after initial procedure. By now, these things are falling out of favor, but there's been no monitoring program set up for these patients. She injures her back at work, winds up in the clinic. One of the PAs sees her, who knows that Tower's on a rampage about the cobalt problems, and he knows she's got a metal-on-metal hip. She checks her cobalt level at 63 parts per billion. And bottom line, she gets revised, she gets better. But she had several years of unneeded morbidity because she was not monitored. This is a Stryker rejuvenate. Again, this was the canary in the mine for taper corrosion because of design issues. And it's the base of the neck there that corrodes like crazy. And this is when I started to notice this is deja vu all over again. Just like the metal-on-metal patients, the latency to symptoms may be a little bit longer, but the key thing is their blood cobalt level is an order of magnitude less than what I was seeing in the metal-on-metal patients. And this likely relates to the difference in the mechanism of the generation of the cobalt, an electrochemical process rather than mechanical wear and particulate debris. This is one of my patients that I was worried was never going to get better. He developed Parkinson's. This is one of my hips, so now we're getting close to home. Not only is it my hip, I decided to save the hospital a little bit of money. This is a Chrome-Cobalt accolade stem, which is kind of their DRG stem. And this is a 36 millimeter Chrome-Cobalt head. And you can see the degree of taper corrosion present. Those are his levels. We repeated this fellow's brain scan at 6 months. It was actually worse. And he's now developed clinical Parkinson's disease. But I saw him now at a year post-revision, and he appears to actually be getting better. So a lesson there, this guy's in his 80s now. And he also experienced 2 dislocations after my modular. I actually took his stem out because I wasn't going to leave a Chrome-Cobalt stem out. He experienced several dislocations, some complications. Now he's doing well, and I'd love to rescan his brain. This can occur on the acetabular side. This is a fractured stem case. She's in this series, not for this hip, but for her contralateral hip, which is also a Depute pinnacle. But on her other side, she's got a 36 pinnacle that's on a Cori stem. This was a pinnacle that was on an AML Bantam stem. She went I saw her about 5 years ago when she had onset of thigh pain skiing vacation. She had a very subtle stem fracture. She had developed surgical osteolysis to a critical level at the metaphyseal-diaphyseal junction, subtrochanteric region of the femur, and had a stress failure of her Chrome-Cobalt stem. The reason for her lysis was adverse reaction to metal debris, a typical one. Usually you see it's more soft tissue and fluid collections, but her problem, what was generating her cobalt, was on the acetabular side, between the Chrome-Cobalt insert and the titanium shell. These are Dartmouth photos. But you can see that patch corrosion there on the socket liner. So that was a 6-hour revision because I had to trephine out her distal stem tip, revised her. She did okay with that. We've been following her expectantly for her other side, for which she's always had some degree of pain. And over the past 2 years, she's developed encephalopathic symptoms related to a fairly minor residual elevation in blood cobalt. And about 3 months ago, I revised her other side, which fortunately was just a modular revision. But this is particularly concerning because I've also got one patient in the series that has a Stryker modular dual mobility. And that's actually a ceramic on plastic, but it's got a Chrome-Cobalt modular liner. And this guy previously on the same side had a Stryker rejuvenant and had the encephalopathy adverse reaction to metal debris related to the rejuvenant. His original primary surgeon revised him to the modular dual mobility, and history repeated itself, and I had to subject him to another revision. And unfortunately, he was infected before. He's been through a 2-stage revision, and now he's in the situation of one of your seniors' talks of having failed a 2-stage and now reinfected my revision of his second cobalt disaster. So I think everyone is becoming aware of the local periprosthetic complications of the metal debris, be it metal on metal or be it corrosion generated. Again, what's new here in my work is what I would call a toxic progeria, which is the neurologic complications of the systemic exposure to the cobalt. This is the review paper that Eric was involved in. These were all extreme cases. And when I talked to the surgeons who worked with industry to develop these implants, my discussions with the presidential line at the American Academy of Orthopedic Surgeons 6, 7, 8 years ago when my paper was published, they said, Tower, this is madness. If this was as common as you thought it was, there should be hundreds of case reports in the literature. Let me tell you, the stuff doesn't get written up. And the cases that are in the literature are the most extreme cases. These are the patients that have required heart transplants, the patients that are deaf, blind, and in a wheelchair. None of my patients in the present series have that degree of involvement. My worst case is my gentleman with the reversible Parkinson's. So these case reports that are in the literature are the very, very tip of the iceberg. I did a cursory review of the literature since Eric's case series review that was published in the Journal of Patient Safety, and there's been at least 8 more case reports, all mainly focused on the cardiomyopathy. Most were metal on metals. Several were the situation of ceramic, wear of Chrome-Cobalt heads by ceramic debris. But if you look at these cardiomyopathy cases, they're terrible. 3 of these patients died and 3 of them required heart transplants. And there's getting to be more series looking at both the neurologic and cardiac effects. Most notable is cases coming out of the Australian VA system showing that the patients who had the metal-on-metal ASR hips are at a much increased risk to be hospitalized for heart failure compared to controls. But there's been other case series suggestive of the neurologic effects to the degree in which I'm seeing them. So, what should we be doing for our patients as orthopedic surgeons? Well, I think there needs to be an awareness for this problem, and we've kind of gone into this arthroplasty mass production model of patients coming through the office on a conveyor belt, and I think follow-up visits can be very superficial, and most of our attention is focused on the joint. But I think these are one of these things. I'm not sure if there's much hope that orthopedic surgery can rectify this problem. I think really my goal is to get this published in the General Medical Journal and get family practitioners and internists to realize this problem exists. Because I think most orthopedic surgeons would prefer the pathway of willful blindness. Because you can imagine what it's like to the normal flow of your office to sit down and spend 30, 45 minutes, an hour with a patient, telling them that you're concerned they might be cobalt poisoned. It really throws a monkey wrench into your production. But the bottom line is, if you have a patient that has some of these symptoms, the test to get is a urine cobalt. If their urine cobalt is greater than 1, I think you should have some concern and ask them some more questions. How did we get into this mess? My belief is, in the United States, the tail is wagging the dog. In arthroprosthetics, it's a market-driven rather than a science-driven enterprise. And the regulation is frankly abysmal and is getting worse. So, and I had no knowledge of the regulation process before I got into this. But the bottom line is, in arthroprosthetics and medical devices, all you have to prove to the FDA is that this new device you're trying to peddle somehow resembles a device that has already been approved or maybe predated the approval process. So the one exception in probably 97% of the hips done presently in this country have had no pre-market studies showing that they are safe or efficacious. And the antecedent device might have been a Charnley arthroplasty, which actually in retrospect looks pretty darn good. About the only pre-market approved device commonly used today is hip resurfacing, which is a bloody disaster. And many of the 510K devices, which is a shortcut process where you only have to show that it resembles something that existed before, some of those are even worse, like the modular metal on metals, where you can get the metal particulates from the bearing wear, and you also have multiple modular junctions with corrosion. We're making these things progressively more complicated and more expensive with no demonstrated benefit. And you can almost show this paradoxical relationship between increased cost and decreased safety and decreased efficacy. The Charnley hip failed at an incredibly low rates. And it was simple. There was no Chrome-Cobalt, it was stainless steel. And then you look at the evolution, which again, I believe is market-driven. So the bottom line is, personally, I believe this is a crisis. If you take a look at 5 to 10 million Americans at risk, an unwillingness on the part of arthroprosthetic industry, and I would say the American Academy of Orthopedic Surgeons in terms of the arthroprosthetic division of that to recognize the problem, being that you go to the Hip Society meeting at the annual meeting, and the guy who's moderating the panel is the design surgeon for the biggest disaster in orthopedic history. Yeah. So the bottom line is, the rest of this is just summary. And I've said it all. You know, I think we're dealing with a big problem. I think most orthopedic surgeons are unaware of it. It's an easy thing to test for and an easy thing to study. And I hope maybe your future generation of chief residents will take it on as a project. Questions?
How difficult is it to get urine and blood strips?
Easy. Yeah. Quest Labs.
And do they have to send away for them anywhere, or they?
Yeah, it's a send out, but any Quest lab, you know, there's a Quest lab on almost every corner of any major city. I mean, there's like 3 or 4 in Anchorage area. So you just send them with a lab slip for urine cobalt.